So, all right. So you're seeing a lot of bladder cancer patients, and maybe we could start out with the folks that you're diagnosing and then the folks that are coming in as referrals to you. And we'll restrict our conversation to high grade, high risk disease, just to kind of keep it digestible. So folks that are coming in to see you, microscopic hematuria, gross hematuria, are these usually just direct referrals to you, or how does that kind of work?
Yeah, so two kind of pots of referrals. It's intragroup referrals. So, people who have seen one of our providers, again, 40 plus providers, doctors plus APPs around Middle Tennessee, probably have an area of about 60-mile radius where we've covered, Middle Tennessee, maybe 40 miles, something like that. So there are a lot of patients that come in through the group, see somebody else. And, for the most part, I think that urologists are good at managing bladder cancer. They utilize the NCCN guidelines. They risk stratify people. We could always do a better job. That's something that I've kind of preached a little bit to the group is, risk stratification, all the stuff we talk about for quality metrics, repeat TURBT, all that stuff. And so if, and then we haven't really been crushed by the BCG shortage. We've been tinkered with here or there. Big groups, as it's historical allocation. So big groups tend to have have a pretty stable supply. So they usually put a request in for BCG at that spot. As you know, there's a lot of stuff going on in BCG naive for clinical trials. And so one thing that I usually do still is look and see if there's an appetite for patients who maybe have another doctor to say, hey, do they want to come in and talk about a trial, right? Some of the younger, healthier patients who maybe have high-grade T1, we've been offering them our intensification trials where they're getting IO agent plus BCG. And there's a lot of excitement about those trials reading out. A lot of them are going to read out actually within 12 months. So that'll be really interesting. And then, so they either get referred in, through a partner but they usually don't come in until they're BCG unresponsive or at least BCG exposed to see if we have a trial or if we would do something different. And then the other pot is kind of outside urologists. So a lot of the rural and the peripheral urologists. One of the things that I've worked hard to do is kind of build some good relationships with some of the doctors out in the periphery, right? Southern Kentucky, Northern Alabama, West Tennessee. A lot of those urologists obviously, don't do cystectomies. They're not that compelled. They don't have access to gemdosi. They don't have access to some of these more complicated treatments. So that's another nice referral base where they send in some of the more complicated patients in and we try to help patients through.
Okay. So maybe we'll start with your practice. They're coming in, they've had hematuria, got a CT scan. You may or may not have scoped them in the clinic. What's your general practice, just out of curiosity?
If I'm seeing a new patient with gross hematuria?
Yeah, and say a CT scan shows a mass in the bladder. Is that a clinic cysto, or do you typically just save that for the OR?
Yeah, if the CT shows something, I'm usually putting them on. I'm usually talking to them. Now, if there's a complicating factor, if they're on Eliquis, if they've had a bunch of stents, if they're a high anesthetic risk, maybe we'll send a cytology and then do a clinic cysto, right? If it's low grade, you might be able to get away with not needing to put them to sleep completely. As you know, you always like to have that initial diagnosis under anesthesia where you can do a good TUR. But yeah, I would say most of the time I prefer to go to the OR.
Perfect. So OR, do you all have residents rotate through, just out of curiosity?
We did. Next time you talk to Sam or Dave, ask them where they went. No, we used to, for a long time, the Vandy residents used to do their private practice rotation with us, which was, just a 4-month block when they were a PGY4. But Vandy's expanded a lot. They've got a lot of sites. So they as of now, they've pulled the resident, but hopefully we can re-engage at some point.
Okay. So when you're doing your TURBTs, are those typically done with blue light enhancement for the first go around, or do you feel strongly?
So short answer is it depends. Usually I would say about half of them, no. We just take them to our surgery center and we just do it under white light. And then based on what I see, then I'll inform my notes and myself to maybe say, okay, if they have a lot of CIS or if they have disease that's, somewhat challenging to see, then maybe we can do it in blue light in the hospital down the road. There are a group of patients who have the state insurance, Blue Cross state insurance. that can only be taken to one of our hospitals that have blue light. So that's a no-brainer. So we just use blue light all the time then. And then there are a group of patients who have HCA insurance, so they can only go to one hospital and they don't have blue light. Again, we talk about the real world. This is kind of the real world, is that a lot of the insurance does guide what we do, but we have access to blue light. So if there's someone who I really think would benefit from blue light, we do it. In the naive situation where I've never scoped them before, I usually don't do that right away.
You know, it's kind of like sometimes when you just sit down with people, the real world and maybe the academic non-real world are quite similar. We don't have towers at every hospital that we go to. It's just not, doesn't make any sense financially, and shipping those towers and equipment around also wouldn't be very effective.